Yes, sir, we can hear you.
Okay, okay. So we're talking about stroke and management in ICU. By way of introduction, stroke or cerebrovascular accident is defined as an acute focal global neurological deficit as a result of a cerebrovascular disease lasting more than 24 hours or resulting in death. If the deficit lasts less than 24 hours, the diagnosis is a transient ischemic attack. The end point of stroke or severe cerebral infarction, which is caused either by a thromboembolic disorders in 85% of cases or by hemorrhage, which accounts for the remaining 15%. All right, a quick revision of the blood supply to the brain. I'm sure we remember the circle of Willis, which is a vascular ring at the base of the brain, which supplies collateral circulation in case of occlusion of any of the blood vessels. So let's remind ourselves that the brain receives blood from two main arterial systems, the arterial circulation, which derives from the internal carotid arteries, and we have the posterior circulation, which is derived from the vertebral-basilar system. And the reason why we need to remind ourselves is that ischemia of any of these branches of the two main arterial systems will produce different types of signs and symptoms. All right, we can see on the right side how this collateral circulation forms. All right, we have the arterial communicating artery. Then we have the middle cerebral artery. We have the posterior communicating artery. And we have the posterior cerebral artery, which forms the circle of Willis. All right. So any blockage or occlusion of any of these vessels supplying the brain can lead to ischemic stroke or any bleeding, all right, from ruptured aneurysm of any of the blood vessels in the brain will lead to hemorrhagic stroke. So ischemic stroke can either be thrombotic or embolic, all right, and usually as a result of a large vessel disease, most of the time which is related to atherosclerosis of the carotid artery or the vertebral-basilar insufficiency. Like we said, the brain receives its major arterial supply from these two artery systems, the internal carotid and the vestibulo-bacillary system. We have the small vessel disease, which leads to lacunar stroke. Most of the time it's due to uncontrolled hypertension or diabetes. And we have cardioembolic stroke, which results from atrial fibrillation, valvular heart disease, or thrombus in the left ventricle. For etiology of hemorrhagic stroke, we have intracerebral hemorrhage, which is commonly caused by hypertension. And then we have cerebral amyloid, angiopathy, and AV malformations. While subarachnoid hemorrhage can be due to aneurysmal rupture, trauma, or sometimes AVMs, all right, arteriovenous malformation. So broadly, this is the types of stroke. All right, we have the ischemic stroke, hemorrhagic stroke, and the transient ischemic attack, which lasts less than 24 hours. Under ischemic stroke, we have the thrombotic and the embolic. And under hemorrhagic, we have intracerebral and subarachnoid hemorrhage. So let's look at acute ischemic stroke. Like we mentioned, we either be thrombotic, which is caused by atherosclerotic plaque rupture, leading to a gradual onset of symptoms, often preceded by transient ischemic attacks. Embolic strokes are caused by thrombi dislodging from the heart or large arteries, and this usually leads to a very sudden, severe onset of symptoms, often without warning signs, all right, and actually affect multiple vascular territories. Okay, so when you see the slide, you can look at the differences between thrombotic and embolic ischemic strokes. All right. They usually, like we said, for acute thrombotic ischemic strokes, they're usually preceded by TIAs, the transient ischemic attacks, and patients who have had 2 or more TIAs within a week are predisposed to developing stroke. And the patients with ABCD score of more than 4, what I mean by ABCD score, age greater than 60 will give 1 point. Hypertension, blood pressure of 140 over 90 and above will give 1 point. All right, the clinical features of speech disturbance, 1 point. When TIA lasts more than between 10 to 59 minutes, 1 point. When there's presence of diabetes, and when there's unilateral weakness, you give 2 points. All right, unilateral weakness and TIA lasting more than 1 hour will get 2 points. So a patient will have ABCD score of 4 and who have had 2 or more transient ischemic attack within 1 week are more predisposed to developing acute ischemic stroke. Okay, strokes are usually traumatic but may result in associated trauma, maybe from the fall due to the neurological deficit, and they usually result in very rapid focal global neurological deterioration. So the common symptoms, we use the fast mnemonic: face drooping, arm weakness, speech difficulty. All right. And when you see this, it's time to call emergency services. All right. Like we looked at the different blood supply. So when the stroke affects the arterial circulation, we call it the anterior circulation stroke. It is associated with hemiparesis, hemisensory loss, aphasia when it affects the dominant hemisphere, and you have what we call hemineglect when it affects the non-dominant hemisphere, usually the right dominant hemisphere. Then it affects the posterior circulation system. We call it the posterior circulation stroke, and usually associated with diplopia, vertigo, dysarthria, and ataxia with cross-sensory or motor deficit. All right, the Barford stroke classification usually classified into 4. We have the total anterior circulation stroke, the partial anterior circulation stroke, the lacunar stroke, and the posterior circulation syndrome stroke. All right, and all of these have their unique characteristics. Okay, so for the total anterior circulation stroke, we have all of the 3. There will be unilateral weakness and or sensory deficit of the face, arm, and leg. You have homonymous hemianopia. Then we have higher cerebral dysfunction like dysphasia, visual spatial disorder. All right, the hemineglect that we usually talk about. The partial anterior circulation stroke will have 2 of the following that we mentioned before, while lacunar stroke will have 1 of the following, which is either pure sensory stroke, pure motor stroke, or you have sensory motor stroke or atasic hemiparesis. All right, for posterior circulation stroke, you have 1 of the following: the cranial nerve palsy, usually the top cranial nerve. We have bilateral motor or sensory deficit. You have conjugate eye movement disorder, all right, what we know as the gaze palsy. Cerebellar dysfunction with ataxia, nystagmus, and vertigo can occur, all right, and isolated homonymous hemianopia or cortical blindness can occur. So this is the Hartford-Osford stroke classification. Then we have the TOS classification of stroke. All right, this is really done by a group, okay, of research, and it classifies stroke into 5, all right, based on the origin of the stroke. So we have the large artery atherosclerosis stroke, the cardioembolic stroke, the small vessel disease or lacunar stroke. Then we have the stroke of other determined etiologies such as vasculitis, dissection, hypercoagulable states, sickle cell disease, or myomyia disease. All right, these strokes usually occur in young patients without typical risk factors. The fifth one is the stroke of undetermined etiology, in which there is no definite source found despite thorough investigation. Sometimes you can have overlap of multiple causes, or there is no identifiable risk factor. The stroke of undetermined etiology usually labeled the cryptogenic stroke. So how does acute ischemic stroke present? It affects all the systems. So for the airway, you can have bronchial breathing or snoring, or may actually proceed to complete obstruction. Breathing-wise, you have Chin-Stokes breathing with tachypnea, bradyapnea. When you have hypoventilation, it's really a late sign. This patient may develop neurogenic pulmonary edema, all right? Neurological system agitation initially, or you can have diminished or reduced state level of consciousness, all right? CVS changes, initially tachycardia and or hypertension. Cushing's syndrome or Cushing's triad usually is a late obneo signs when you have hypertension with bradycardia. All right, ECG changes may actually occur, especially with subarachnoid or intracerebral hemorrhage, and atrial fibrillation usually associated with thromboembolic events. All right, renal, you can have incontinence. We have the National Institute for Head Stroke Scale, all right, which is used to assess the severity of an acute ischemic stroke event. All right, it helps in clinical decision making. It helps in predicting outcomes, and it can usually be used to monitor neurological status over time. The NIHSS scale, all right, consists of 11 items. Each item assesses a different aspect of neurological function. You have a total score ranging from 0 to 42, with higher scores indicating more severe strokes. The items that are scored are found on the right side, okay, of the screen. So you just, because of time, we just go over them. But the significance of the NIH score is in interpreting. All right, when the score is 0, there are no stroke symptoms. 1 to 4, minor stroke. But from 16 to 20, we're talking about moderate to severe stroke. With a score of 21 to 42, severe stroke. The clinical significance has to do with initiating therapy and prognostication. When you have NIHS score greater than 6, you want to consider intravenous thrombolysis. Your heart is placed within 4.5 hours of onset of symptoms. With a score of greater than 10, it shows that most likely there's a large vessel occlusion involvement, and you want to consider mechanical thrombectomy if the patient presents within 24 hours of onset of symptom. With NIHS score greater than 25, all right, it indicates severe stroke and usually associated with poor prognosis. Okay, investigations as indicated, all right, but brain CT is very important, all right, and because it is used to clarify the diagnosis, the extent of cerebral infarction, and it also helps to differentiate infarct from other sources like hemorrhagic stroke and to exclude hydrocephalus. All right, echo is important because you want to rule out cardiac sources of emboli in cardioembolic stroke. All right, ECG, all right, so look out for features of AF. And the carotid Doppler studies is used to identify the presence of stenosis in the carotid arteries in about more than 70% of cases. Other investigations that may be of benefit include all of this, and investigations are requested for as indicated. All right, there's what we call the malignant stroke. All right, this is actually sometimes a complication of acute ischemic stroke. It may even occur from the onset. So a malignant stroke refers to a large ischemic infarct, typically involving the middle cerebral artery, and it leads to significant cerebral edema, mass effect, and intracranial hypertension. Malignant strokes are usually associated with high mortality. About 8 out of 10 patients will die if there are no immediate urgent intervention. And some of them will come down, those that survive will come down with severe neurological disability. All right. Malignant strokes are usually managed in the ICU with osmotherapy, with your monitor or hypertonic saline. All right. Permissive hypertension, all right, usually used if there are no risk of hemorrhagic transformation and the patient is not anticoagulated. Hyperventilation, you want to keep your PaCO2 between 30 to 35. Okay, it helps to manage your intracranial hypertension. For patients who are less than 60 years, surgical intervention may be indicated with the compressive hemicraniotomy. All right, seizure management, if they occur, but malignant stroke, you do not give routine anti-seizure prophylaxis. That's one of the differential diagnoses. Let's go on. And in acute ischemic stroke, an urgent CT is usually required if there are indications that this patient qualifies for thrombolysis or early anticoagulation. You want to rule out any intra or subarachnoid hemorrhage. All right. If there is evidence of trauma, okay, you want to give the patient, you want to quickly order for a CT. If the patient is on anticoagulation or has any no bleeding tendencies, all right. If there is rapidly progressive, inconsistent, poorly localized or fluctuating neurology, or there's involvement of the brainstem, urgent CT is required. If the patient has a low level of GCS, any GCS less than 13, then you have other features like papilloedema, fever, or meningism. And if the patient had a severe headache at the onset of neurological symptoms, these are some of the indications for urgent brain CT for patients with stroke. All right, so features of brain CT in acute ischemic stroke, they differ depending on the time of onset. The early ischemic changes usually occur within less than 6 hours of onset of symptoms, and on brain CT, you see loss of gray-white matter differentiation. They commonly call the insular ribbon sign. All right, there's hypoattenuation of the affected brain regions. There's sulcal effacement, which is usually due to early cytotoxic edema. Then when you see a hyperdense lesion on the middle cerebral artery, it suggests an occlusive clot in the middle cerebral artery. All right, this is usually seen within minutes to hours of symptom onset. Between 6 to 24 hours, the attenuation in the affected brain worsens, and there's increased sulcal effacement, which is due to increased cerebral edema. There's midline effect, which mass effect, where the midline shift in light infarcts to the affected area. Within 24 hours to 1 week, we have well-demarcated hypodense region with progressive swelling and possible brain herniation. All right, the picture on the right of the slide is compares a normal brain and an abnormal brain. All right, you see the normal brain tissues circled green, and this is the hypodense lesion on the affected brain. All right, this is an acute infarct. Sometimes an ischemic stroke may undergo hemorrhagic transformation, all right, where you have petechial hemorrhages or parenchymal hematomas in the affected tissue, especially in patients who are thrombolized. All right. Subacute or chronic stroke, which is more than 1 week, you have gradual volume loss, cerebral volume loss, gliosis, and encephalomycia. All right. So yeah, it's important for you as intensivist or an anesthetist rotating to the ICU to be able to read a brain CT and be able to pick, all right, hypodense lesion, okay, especially with patient presenting with signs and symptoms of acute ischemic stroke. Okay, there are different imagings, like I mentioned before, all right, for the no-contrast CT, the early signs less than 6 hours, you have the loss of gray-white matter differentiation, hypoattenuation, and when the stroke is more than 6 hours, you have well-demarcated infarct with surrounding edema. All right. Sometimes you may want to do CT perfusion, all right, imaging, which will help you to identify the penumbra, all right, surrounding the core infarct. The penumbra area talks about salvageable brain tissue, okay. The core infarct, you would see there's markedly reduced cerebral blood flow and cerebral blood volume, all right. In penumbra, there is preserved cerebral blood volume, but there's reduced cerebral blood flow, okay? Early intervention is important, all right, to reduce the amount of brain tissue affected, especially in the penumbral region, which you can see on your CT perfusion imaging. All right, CT angiography sometimes is very important because it helps to detect large vessel occlusion, especially occlusion in the internal carotid or the vertebrobasilar regions. It also helps to identify intracranial and extracranial stenosis, and you can look at the adequacy of the collateral circulation at the circle of Willis. We have the diffusion-weighted imaging MRI. All right, this is very sensitive for early infarction, detects changes within minutes. All right, although CT is still the gold standard, but sometimes when CT cannot is equivocal, you can do a diffusion-weighted imaging. All right, so management, quick. We need to reperfusion therapy, all right, especially in acute ischemic stroke, and you do that with your IV thrombolysis, your tissue plasminogen activator, or your Arteplase. You need to administer this at a dose of 0.9 milligram per kg with a maximum dose of 90 milligram. The 10% of your calculated dose is usually given as bolus, while the other 90% you infuse over 60 minutes. And this should take place within 4.5 hours of onset of symptom. All right. Intravenous thrombolysis with Arteplase should be taken very seriously. Number one, you want to rule out contraindications to this medication. So when there is hemorrhages on your image, and this is why it's important for urgent CT in order for you to determine to reperfuse the brain or not. So hemorrhage or bleeding on imaging, recent major surgery, or if there's any past history of stroke within the past 3 months, patients with uncontrolled hypertension, all right? If you want to thrombolize, you must make sure that the blood pressure, systolic blood pressure is less than 180 and diastolic less than 110. Patients who are coagulopathic were INR of 1.7, more than 1.7, and patients who are thrombocytopenic with platelet count of less than 100,000 per millimeter cube millimeter, all right? So you need to, before you reperfuse or thrombolize, you want to rule out contraindications. All right, blood pressure control in case of acute ischemic stroke. If the patient does not qualify for thrombolysis with your TPA or Arteplase, you want to allow for permissive hypertension. But the blood pressure, The systolic blood pressure should...
I can switch it.
Please, when you are coming in, please, can you just mute yourself, okay? If there's no thrombolysis, all right, the patient does not qualify for it, you allow permissive hypertension. And this is important, all right? You know, because rapid lowering of blood pressure can increase infarct size on the brain, okay? Post thrombolysis, you want to maintain your systolic blood pressure less than 180, all right? And it's important to choose your antihypertensive agent in trying to lower your blood pressure. Labetalol nicardipine is usually preferred for blood pressure control in this group of patients. All right, other modalities of care is you want to maintain your glucose level between 140 to 180 milligram per DL. You want to avoid hypoglycemia, which will also worsen the ischemic damage to the brain. Fever worsens neurological outcomes, so you want to maintain normothermia as much as possible with antipyretics and external cooling measures. You want to prevent hypoxia and hyperoxia, so you want to maintain your SpO2 a little greater than 94%, but you want to avoid anything PaO2 greater than 100, okay, and PaO2 less than 60. These are some of the adjunct management for ischemic stroke. Aspirin 300 milligrams should be given to patients, all right, and unless you are thrombolizing them, right? But if the patient is going to thrombolyze, you need to withhold aspirin for 24 hours. And patient with ABCD score greater than 4 or with TIH, okay, which has occurred more than 1 week, you want to give aspirin. Sometimes neurosurgical intervention may be needed in patients with acute ischemic stroke if they have associated hydrocephalus or there's a large infarcted area in the middle cerebral artery territory. All right, this is sometimes qualified for our definition of malignant stroke. The compressive craniotomy, all right, is reserved for patients with malignant stroke who are 60 years old and below. Okay, it's important for us to ensure that the appropriate patients are taken for surgery. All right, signs on CT scan of an infarct of at least 50% of the middle cerebral artery requires decompressive craniotomy. Antiplatelet therapy, mentioned this before. All right, for patients with cardioembolic stroke, you need to anticoagulate them. All right. Warfarin can be started 3 to 14 days based on the size of the cerebral impact. All right. They directly acting oral anticoagulant, all right, like apicepan should be used, and within 3 to 14 days you can start warfarin. And this is only reserved for patients with cardioembolic stroke. Okay, lipid management, high intensity statin should be continued if the patient on it. And if not, you want to start with atorvastatin or rosuvastatin and appropriate dose to reduce future stroke. Lifetime and risk management, factor management is important with your BP control. Okay, diabetes, ensuring that your HbA1c is less than 7%. Stop smoking and regular exercise. So for acute ischemic stroke, you want to undergo brain CT within 24 hours of presentation if possible. You want to ensure adequate hydration and nutrition. Aspirin should be continued until an alternative antiplatelet therapy is started. All right, you want to continue and maintain priostatin therapy. All right, like I mentioned, cardiac lesions are the only definitive indication for full anticoagulation in patients with stroke. You want to ensure adequate analgesia and DVT prophylaxis. I mentioned this before, lowering blood pressure may stand the infarct, so you need to be clear at what point, all right, does your patient require lowering the blood pressure, okay? And if the blood pressure is around 220, 30, you want to reduce it slowly so that you don't increase the cerebral infarct. I mentioned this before, investigate and treat fever aggressively, and aggressive fissure, all right, may be important. And consider initiating treatment that will help to modify cardiovascular risk factors. Okay, these are specific guidelines on thrombolysis with arterplace. I'm sure by the time you get the lecture slides, you'll read it yourself. Okay. Now, complications. Acute ischemic stroke may be complicated with neurological deterioration. All right. And this is actually a cause for neurosurgical consult. So you want to monitor your NIH-SS score and do serial neuro checks. You want to watch out for malignant cerebral edema, especially in patients with large infarct. All right. Once you're able to make a diagnosis of malignant cerebral edema, cerebral stroke, malignant stroke with cerebral edema, intracranial hypertension, you want to treat with osmotherapy or the compressive hemicraniectomy. Other complications are seizure disorders, although routine anti-seizure prophylaxis is not indicated, routine seizure prophylaxis is not indicated, but if they occur, you want to treat, all right? You want to prevent DVT with early mobilization, or you want to use your intermittent pneumatic compression, all right? And consider low dose clozine or your Lovenus, as the case may be, all right? But you want to ensure that there's no hemorrhagic transformation of your ischemic stroke. Okay, this is just this. So management of acute ischemic stroke in the ICU involves timely reperfusion therapy, hemodynamic optimization, neurological monitoring, and prevention of secondary complications, like we mentioned. Always involve an interdisciplinary team, including neurologists, intensivists, rehabilitation specialists, and nursing care. All these are very crucial for improved outcome following stroke. All right, let's see how far we can go. We've talked about ischemic stroke, so let's quickly go over to hemorrhagic stroke. This is more common for us in ICU. Okay. Like I mentioned, hemorrhagic stroke can either be intracerebral bleed or subarachnoid hemorrhage. Okay. All right, this is a clinical scenario. I don't think we have time for that. Okay. Intracerebral hemorrhage is bleeding directly into the brain parenchyma, okay, which will lead to mass effect, intracranial hypertension, and secondary brain injury. Hypertension is the most common cause, responsible for about 50 to 60%. All right. Cerebral amyloid angiopathy in elderly patients who are on anticoagulation, developing coagulopathy. All right. Patients with arteriovenous malformations, trauma, tumors, or patients with illicit drug use. All right. These are some of the common causes of intracerebral bleed or intracerebral hemorrhage. All right. How does it occur? The pathophysiology. Primary hemorrhage occurs, all right, from rupture of small penetrating arteries due to chronic uncontrolled hypertension or amyloid angiopathy, like we mentioned, in elderly patients. Now, this will lead to secondary injury with mass effect, all right, increase in blood volume or blood flow will cause increase in intracranial pressure, and this will cause brain herniation, all right. Then we have perihematoma edema, leading to inflammatory response with further brain damage. Neurotoxicity may result from breakdown of blood products like hemoglobin, iron, and inflammatory cytokines. Intracerebral bleed occurs in different locations in the brain. Just remember, brain trauma can lead to problems all right? It's usually commonly located in the basal ganglia, all right, which accounts for about 35 to 50%. In the thalamus, 10%, pons, 10%, cerebellum, 10%, and we can have lobar hemorrhages, which accounts for 20%. This is usually due to amyloid angiopathy. Okay, so how does intracerebral hemorrhage present? There's usually a sudden onset of focal neurological deficit, okay, which is similar to ischemic strokes. Headaches is less common than subarachnoid hemorrhage, all right, but may be present in large hemorrhages. There's nausea and vomiting due to intracranial hypertension. Patient may have reduced or altered mental status or may be in coma, especially if they affect local and distal hemorrhages. Seizures usually are more common in lobar hemorrhages. All right, diagnosis, you want to do a non-contrast CT, which is the first line and most rapid. You will see hyperdense lesion in the brain parenchyma, which is surrounded by hypodense lesions due to edema, usually a midline shift. And this picture, all right, on the right side shows a very large hyperdense area in the brain parenchyma. So this is an intracerebral bleed. It's important for you working in ICU that you're able to locate this in time. You can see the mass effect, all right, a shift, midline shift from this side to this side, from the affected side to the contralateral brain side, okay? And this may actually lead to herniation of brain, and you can have a sudden cardiorespiratory arrest. Okay, so MRI with substituted imaging, we identify microbleeds, usually useful for elderly patients with amyloid coagulopathy, angiopathy. Laboratory tests, most of the time, like we said, they may have coagulopathy, so your protobenzyl INR and your APTT is important to assess bleeding risk. Toxicological screen, all right, for patients who are suspected to be illicit drug users. Okay, so you want to ICU management of intracerebral bleed. If the GCS is less than 8 or the patient is at risk of aspiration, you want to secure the airway and maintain nausea and normocapnia to prevent secondary brain injury. All right, you want to target your systolic blood pressure between 140 to 160 and avoid rapid drop in blood pressure. All right, your preferred agents are nicardipine and labetalol. I usually don't like hydralazine, all right, in this group of patients. All right. So for patients who are coagulopathic, you want to reverse anticoagulation with warfarin. If warfarin is what the patient is on, you want to give protropic complex concentrate, which is your PCC, with your vitamin K. All right. And for patients who are on heparin, you want to give protamine sulfate. For patients who are thrombocytopenic, you want to institute platelet transfusion, especially if the platelet is less than 50,000. So reverse of anticoagulation is important in cases of intracerebral bleed. Okay, for patients who have features of intracranial hypertension, you want to institute measures, all right, to reduce or manage ICP, elevate the head of bed, osmotherapy, external ventricular drainage by the neurosurgeon is indicated, especially if there are features of hydrocephalus. All right, treat seizures when they occur, and decompression of large hematomas. All right, when the hematoma is more than 13 ml in deteriorating patient or patient with posterior fossa hemorrhages. All right, all these patients require urgent surgical evacuation. Okay, so subarachnoid hemorrhage, all right, and this is quite common, right? And that's why we just want to spend some few minutes to talk about it. So you see a patient with 45-year-old female patient with a sudden severe headaches who has just collapsed, and on the CT there's evidence of subarachnoid hemorrhage. And CTA, the CT angiography reveals anterior community artery aneurysm, which are just ruptured, all right? So you discuss your management. Subarachnoid hemorrhage is bleeding to the subarachnoid space, often due to ruptured cerebral aneurysm, or sometimes maybe due to trauma. All right, aneurysmal subarachnoid hemorrhage accounts for 85% of cases. No aneurysma due to trauma or AV malformation vasculitis accounts for the rest, which is about 15%. All right, higher incidence in females and patients with hypertension. Okay, this is an aneurysm just to remind us. A cerebral aneurysm is a focal dilatation of the cerebral artery, all right, which can rupture and cause a subarachnoid hemorrhage. We have different types: the circular or berry aneurysm, which is the most common and usually occur at arterial bifurcations. Okay, we have the fusiform aneurysms, all right, which involves the entire circumference of the artery. Mycotic aneurysms are caused by infections. All right, so when there's a dilatation, a focal dilatation of a cerebral artery, all right, with a increased risk of rupture, the patient may come down with subarachnoid hemorrhage. All right, don't forget this, the circle of Willis, and all these are the arteries that are involved, all right? And all of this, aneurysm can form in any of the branches. The fusiform aneurysm usually at the bifurcation, okay? And we have different types. The common one is actually at the middle cerebral artery, which accounts for about 39% of cases, okay? The anterior communicating aneurysm, all right, accounts for about 24%. And aneurysm around the basilar system accounts for about 10%. So risk factors: hypertension, smoking, and genetic disorders. So subarachnoid hemorrhage pathophysiology, SAH, all right, there's a sudden rupture of an aneurysm, all right, and blood enters the cerebrospinal fluid, leading to increased intracranial pressure and with reduced cerebral perfusion. And because of this, there's inflammatory response, which is elicited, leading to vasospasm, which will lead to delayed cerebral ischemia. Hydrocephalus usually occur due to impaired CSF absorption. So you have all of this taking place with subarachnoid hemorrhage. There are different scores, all right, based on different parameters. The World Federation of Neurosurgeons score is based on the best initial neurological status after the bleed, okay? And it's usually, most of the times you hear your neurosurgeons talk about it, and it will be good for you to follow what they're talking about because it will help in your management. So when the GCS is 15 with no motor deficit after the initial bleed, you have a WFNS score of 1. But if the GCS is 7 to 12 plus motor deficit, all right, you have a score of 4, WFNS score of 4. But if the GCS is between 3 to 6, all right, which whether motor deficit present or not, you have a WFNS score of 5, which is severe. Then on CT, the Fisher scale is based on CT presentation, appearance of blood clot, all right? So if there's intracerebral or intraventricular clot, all right, you have a Fisher score of 4, and all this determine prognosis of this patient. Clinical presentation, you have a sudden severe thunderclap headache. The patient usually described as the worst headache of their life. This is associated with altered consciousness and amnesia, and the patient would have hypertension, hemiparesis, and hyperreflexia. Sometimes they have cranial nerve deficit, especially the third cranial nerve palsy, which affects the posterior communicating artery aneurysm. There are usually some form of hemiparesis or focal neurological deficit. All right. Let's just go to the CT findings. It's important for you to be able to recognize subarachnoid hemorrhage on your CT, and you have an hyperdense material commonly in the basal systems or sulci or ventricles, and you have what they call the starfish pattern. All right, you have the starfish pattern. Let me see if I have, okay. All right, let's just go on with that. So you have the starfish, all right, pattern, all right, on the basal systems, which is a suggestive aneurysm, also aneurysm and subarachnoid hemorrhage. Then you can have CT angio, all right. All this blue arrow is taking you to the aneurysms, okay, with the digital suppression angiography, which is the gold standard for detecting aneurysm, all right. It's highly sensitive and specific. All right, CTA is usually done after non-contrast brain CT. All right, and sometimes this is preferred over performing an invasive procedures like lumbar puncture. Lumbar puncture, if the CT is negative, all right, you see xanthochromia. Okay, you can see xanthochromia, yellowish coloration of the CSF, which is due to red blood cell lysis. This usually develops within 2 to 4 hours after an acute hemorrhage and should be present after 12 hours. All right. If you look at the red blood cell count, all right, it's usually very high. All right. If the red blood cell count in patients with subarachnoid hemorrhage is about 2,000 plus, all right, this is usually diagnostic of cerebral hemorrhage, especially if your brain CT is inconclusive. MRI may be done, all right, which although the CT is the gold standard, but it usually helps, especially in detecting subarachnoid hemorrhage in the first 2 days. Okay. All right. So there are types of brain. So what are the criteria for admitting a patient with subarachnoid hemorrhage to the ICU? A low GCS, persistent neurological deficit, patient with hydrocephalus, all right, or features of intracranial hypertension, and patients who are at the risk of rebleeding. Okay, ICU management, if the GCS is less than 8, you want to intubate and maintain your airway, all right, ventilate the patient to pneumonia or pneumocapnia. All right, the goal, the blood pressure control goal is you want to keep the systolic blood pressure less than 160 millimeters of mercury. Don't forget that some of these patients usually hypertensive, so you want to keep the blood pressure, systolic blood pressure less than 160. And this is very strict, it's very important to strictly follow these recommendations. All right, you want to prevent the, once an aneurysm has ruptured, all right, you want to prevent rebleeding, and this is done surgically by endovascular coiling, or they can do surgical clipping. Tranexamic acid, the period is usually controversial, with a lot of people preferring not to give it. Okay, the non-surgical management of patients in the ICU, you follow the SAH mnemonics. You want to sedate the patient with standard sedation protocol and give saline, all right, at 30 to 40 ml per kg, and ensure that you prescribe stool softener for the patient because you don't want the patient to strain, all right, with the risk of rupturing an aneurysm. Adequate analgesia with opioids and non-steroidal anti-inflammatory drugs. Anti-seizure prophylaxis is indicated here, all right? And you want to give anti-vasospasmic like your nimodipine. Triple H, although it's very historic and some people still do it, all right? You want to keep the blood pressure between 140 and 160, and you want to maintain hypervolemia and hemodilution. All right, surgical management, endovascular cooling, which is preferred for most aneurysm, is a catheter-based approach via the femoral artery. All right, and you can do surgical clamping, craniotomy and placement of the titanic clip at the aneurysmal neck. All right, it's more definitive, although it requires open surgery. And the anesthetic considerations, all right, if you're going to anesthetize a patient with aneurysma bleed for surgical clipping. These are some of the things you need to consider, all right? When you have the slide, you go through it, okay? So immediate post-op, once the patient comes to ICU, all right, there are some things you must do. You want to ensure that the patient is hemodynamically stable and the airway is secured. Usually, I like to keep them ventilated for between 24 to 48 hours, or except in cases where neurological assessment will require you to wake the patient up earlier. You want to perform a detailed neurological examination using your GCS and look out for any sign of new neurological deficit. Monitor for signs of increased ICP and make sure your systolic blood pressure is always less than 160 millimeters of mercury. All right, this is to prevent rebleeding. It's important that you use your invasive blood pressure monitoring, all right, so that you can see beat-to-beat changes in the blood pressure. All right, maintain euvolemia with your saline infusion and conduct hourly neurological check. Monitor ICP, all right? Sometimes you may not be able to move the patient to the CT room, but we do what we call the optic neck sheath diameter, which is a bedside non-invasive procedure. If the optic neck sheath diameter is less than 5 or greater than 5 millimeters, usually very indicative of raised ICP, okay? You want to provide supplemental oxygen or mechanical ventilation may be required to ensure your SpO2 is greater than 94%. So your target therapy for subarachnoid hemorrhage in the ICU is what I've shown you here. SpO2 between around 94 to 97, or you want to maintain PaO2 at least 97.5 millimeters of mercury. PCO2 between 35 to 45. Your systolic blood pressure must be kept below 160 and your ICP less than 20 millimeters of mercury. All right, there are a lot of complications with subarachnoid bleed. You have the vasospasm, all right, or delayed cerebral ischemia, which peaks around between 3 to 14 days after subarachnoid clip. So you want to do, how do you prevent this? Triple H therapy. You want to give nimodipine 60 milligrams every 4 hours to reduce the risk. And sometimes endovascular interventions with your intra-arterial vasodilators or balloon angioplasty may be needed. A lot of patients will be complicated with hydrocephalus, and this is where most times the surgeons will put an external ventricular drain if it's acute, and if it's chronic, they want to do a VP shunt. Consider prophylactic anti-seizures in this group of patients. Okay, prognosis, mortality is between 10 to 50% within 30 days, and poor outcome usually with high Hunt and Hayes score, rebleeding, and hydrocephalus. When the patient's aneurysm is repaired early and the patient is younger and with good pre-morbid status, they usually have favorable outcome. Okay, in conclusion, all right, subarachnoid hemorrhage is a neurosurgical emergency which requires rapid diagnosis and intervention. ICU management focuses on preventing rebleeding, managing complications, and you want to optimize neurological recovery. Multidisciplinary care improves survival and functional outcome. Thank you. Yeah, we made it today. So that is the end of the presentation. Any question and suggestion? Let me stop.